Okay, so this is going to be our first pharmacology course, and of course we're doing bugs and drugs, section 1. This is mainly, this first unit is going to be covering a lot of some of the principles behind how we use our antibiotics and why we use them the way that we do. So we'll talk a lot about pharmacodynamics and pharmacokinetics, which you guys have covered in your first pharm class, right? So if I say something like volume of distribution, you guys know what that means, correct? Hopefully. We'll cover it again if we need to. A couple of really good guides that are useful for looking up things related to infectious disease. Have you guys seen the Sanford guide before? So Sanford Guide's a really good book. Hopefully it is available through your library. I haven't actually checked that out to see if you guys have that through your websites. But Sanford Guide is going to be one of your standards to go to in regards to bugs and drugs, right? So lots of good information in the Sanford Guide. They come up with a new one every single year because, as you might know, infectious disease changes all the time, right? You'll have different emerging resistant pathogens. You'll have different drugs that maybe go out of vogue, some that come into vogue. And so Sanford Guide kind of captures a lot of that stuff. And so some of the nice things they have include things like spectrum of activity. So they'll have nice big color charts where you can look at, say, if I want to see if penicillin covers this particular bug, I can look down a chart and just see, okay, this is going to cover this one, has no activity, has some activity, or, you know, or not, right? So it's really good for having information like that. So if your patient has, say, a culture that comes back and says they're growing out Pseudomonas, what's going to be a good antibiotic to cover that, you can look in there and see, okay, this is all the drugs that cover Pseudomonas, right? And so it's really handy for that sort of thing. The other thing they have as well is they list drugs of choice based on the indication. So you'll have something like, you know, I have a patient who has a diabetic foot infection. Okay, well, what's going to be my potential causative organisms? What's going to be my drug of choice for that? If they have an allergy, what's my second line choice for that? And it's really good for giving you at least, you know, an initial empiric therapy for whatever kind of is ailing your patient. So it's really useful for that. And then they also have, you know, just alphabetical list of all the different antibiotics and list of adverse drug reactions and drug interactions, all kinds of other stuff. So Sanford Guide is a really good thing to use, especially when you're out on your rotations. Tarascon is another one. I've never personally used this one, but I'm sure a lot of you guys are at least somewhat familiar with it. I'm sure you'll see them out in clinical practice. This is also useful for listing out different drugs and what are going to be drugs of choice for different disease states and things like that. So you certainly that could be another resource for you guys. Okay, so the first thing we'll cover are going to be some of our bacteria. Have you guys had microbiology yet? Okay, so this is going to be like a really kind of high-level overview of some of the microbiology stuff. I'm not going to get really into super detail, only so much as it pertains to the medications we're going to be using. So certainly we have different categories of bacteria. The main two categories we'll kind of be focusing on are going to be the gram-positives and our gram-negatives. Obviously, that's kind of differentiated based on how they respond in the gram stain. I'll show a picture of that in a second. The person who made these slides before me, and you'll see that some of these are old slides plus my new slides, so just be aware of that. If I see something, I'm like, that's kind of weird, but I probably missed it when I was actually going through. So gram-negatives, they kind of listed these as either wimpy bugs, kind of the medium gram-negative bugs, and then your space bugs. Does anyone know what space bugs are? Things that grow out in like asteroids and stuff. Not quite that space. We'll talk about those in a second. Those are really important to know. You also will have your anaerobic bacteria, which means what? Yeah, they don't need oxygen. So there's going to be certain organ sites where anaerobic bacteria are more likely to pop up. Like, what do you think might be an anaerobic site for bacteria to live on the body? Like, how about the gut? Gut's a really good one. The mouth has lots of anaerobics to live in. Anywhere is really without a lot of oxygen, that's going to be a good place for anaerobes to live. Also atypical pathogens as well, so they don't really fall into one of these other categories. And you'll see that the anaerobes can either be gram-positive anaerobes or gram-negative anaerobes. But really, in general, when we talk about what drugs are going to be good to cover those bugs, we'll just kind of talk about atypicals as a one category. So again, some of our common gram-positives you're going to run into. One of the big groups is going to be Staphylococcus, and so we have different varieties like Staph epidermidis. Where do those live? On the skin. That kind of makes sense. You also have your Staph aureus, and so this is going to be coagulase positive staph. And the two main varieties that we'll talk about with this include MSSA, which stands for methicillin susceptible Staphylococcus aureus, and then you have your MRSA, which is methicillin resistant Staph aureus. If you had to guess what kind of drug methicillin is, what would you think? Penicillin, right. So it's actually an old school penicillin that we don't really use anymore, but we'll talk about the category this falls into. But that's where that name comes from, is that we originally used methicillin to see if it was going to be, the bacteria was susceptible to it. And you kind of found that there's two varieties of Staph aureus, some that were susceptible and some that weren't. And as you might have heard, like, news stories and things like that, certainly MRSA is going to be, is on the rise, not only in the hospital realm, but also in just the community, big rises in rates of MRSA. We then have things like streptococcus, so things like strep pneumo. You have group A, B, C, G strep. Those will pop up in different areas, especially when we talk about ENT infections. Those will pop up there. And then also some other important ones include Enterococcus, faecalis, and then Faecium. Where do you think Enterococcus falls, or where they live? Probably in the gut, right? Yeah, so that makes sense. We also have your gram-positive anaerobes, and so you're going to see these pop up. Certainly Clostridium difficile is going to be one of the big ones we'll talk about, but things like Peptococcus, Peptostreptococcus, those usually end up living in the mouth. So you see a lot of, when you're covering for certain types of animal bites or people bites, oftentimes you're covering with drugs that will be useful against those type of anaerobes. And then one of the big ones we'll talk about, especially in regards to adverse reactions or different sequelae that can come about from using antibiotics, is going to include Clostridium difficile. You guys have heard of C. diff infections, right? You can usually smell it a mile away. It's really, really nasty, but a lot of times it's coming around secondary to the use of antibiotics. Does anyone know why that is?
It kills off the flora.
Absolutely right. So we're giving exogenous antibiotics that are killing off our normal gut flora, and all of a sudden C. diff is like, hey, you got all this prime real estate, let's go ahead and set up shop here, and then all of a sudden now you have pseudomembranous colitis, all kinds of bad stuff can happen. So that's usually where you see a lot of C. diff infections coming from. Your gram-negative bacteria, these are going to be your gram-negative aerobes. So again, these are utilizing oxygen. So kind of the wimpy ones, the ones you'll see that are generally susceptible to a lot of different antibiotics, include things like Haemophilus influenza, your Moraxella catarrhalis. You see these a lot in some upper and lower respiratory tract infections. Also things like Shigella, Salmonella will pop up here. You kind of get into more of your medium, a little bit maybe more difficult to treat in some cases, antibiotics. Things like E. coli. You have things like Klebsiella pneumonia, you have Proteus. And then you have your space bugs. And space bugs are really set up here. You can see the acronym. So it includes things like your Serratia, your Pseudomonas, your Acinetobacter, Citrobacter, and Enterobacter. Those are all going to be gram-negative bacteria that are more likely to develop really significant resistance to a lot of drugs. So if you ever hear of like an MDR pathogen, that means multi-drug resistant pathogen, right? So these are the guys that are going to be very, very difficult to treat. And when you get your culture results back, it's going to say resistant to this, resistant to this, resistant to this. You get this one drug that's super toxic. That's the only one you got to go with, right? So it can be very, very difficult to treat, especially with a lot of toxicities we'll see with some of these antibiotics.
So you said a lot of them become resistant?
Yeah, they either, you will see that based on, we'll talk about different pathways for resistance to develop. You'll see that they just inherently will develop resistance over time. So especially, depending on the site you're at. So if you imagine somewhere like a medical ICU, where you have lots of different courses of antibiotics being given, you have a lot of broad spectrum. We'll talk about what that is in a second. A lot of big guns being given. That is just going to be putting the selective pressure on those bacteria to develop these really resistant, nasty bugs that are very difficult to treat. Now, if you imagine something like a med-surg unit, where maybe a lot of people are getting kind of more narrow spectrum antibiotics, or you get a lot of like surgical prophylaxis, things like that, you're less likely to see those really resistant bugs. This is like, you see a lot more in healthcare acquired pneumonias and other type of nosocomial infections. So think about like nursing home patients, think about ICU patients, especially those who are on ventilators. Those are the ones that are more likely to get those kind of bugs. Good question. So again, just to kind of reiterate this, if you ever see the escape term, this kind of goes along with the space organisms. This just includes Klebsiella. This is starting to realize that Klebsiella is also going to be a significant source for resistance as well when we talk about some of the products that they can produce themselves. But again, just another way to kind of organize some of your gram-negative bacilli here. Yes?
My family member was in the hospital for Klebsiella-based pneumonia. Is that why they prescribed one of the stronger antibiotics?
If it was one of the, so the question is, I'll just repeat it first, that way the microphone picks it up. So you said you had a family member who was diagnosed with Klebsiella, probably a pneumonia,
Yes.
if I had to guess, yeah. So they probably were using one of these like kind of big gun antibiotics, either because it was resistant or if they were starting out with empiric therapy, especially if you are worried about multi-drug resistant bacteria. They start out with a couple different antibiotics in some cases to make sure they kind of cover everything, and that way they're more likely to have, at least one of those drugs is going to likely be effective against that bug, right? So most likely it was either a very resistant bug or they were starting with empiric therapy.
Okay, because I thought it was really weird that they prescribed it. It starts with a T. I don't remember how to.
The tigecycline.
Yes, and my family in medicine, they were all concerned why this doctor was going straight to one of the strongest antibiotics.
Yeah, that depends. We'll talk about tigecycline a little bit later, but I've seen usually whenever I see someone use tigecycline, it's going to be in a case where they are growing really nasty gram-negative bugs that really isn't being covered with anything else, and so that's kind of like a last-ditch effort. So if I see some really bad Acinetobacter infection, especially secondary to ventilator-acquired pneumonias, I'll sometimes see tigecycline for that. The problem with it is, we'll get to it later, but there's some issues with it that make it not really an ideal antibiotic as compared to some of the other things that we might potentially use. So, okay. So our anaerobes, so again, these are going to be surviving in the absence of oxygen. Again, you're going to see these a lot in mucous membranes. GI is going to be a big source for anaerobes. We'll have deep puncture wounds, things like that. Certainly, like mentioned, the genital areas are another potential source for anaerobes. They can either be gram-negative or positive, and so some of the big ones you'll see here, like we said, include Clostridium, Bacteroides, and also this Petrostreptococcus. And then you have your atypicals. These are not really either gram-positive or negative. That's why they're atypical. They don't really fall into one of these categories. And so the big ones you'll see being treated here include things like chlamydia, mycoplasma, and also Legionella. So this is where you'll see that certain antibiotics will have good coverage against atypicals. A lot of them do not. So you might see, that's why you see a lot of things like azithromycin being utilized for some pneumonias, because they worry about things like atypical pathogens. We'll talk more about that when we get to the pulmonary section. Okay, so to understand how a lot of these antibiotics are going to work, it's important to know a little bit about the cell wall basics. And so again, having a cell wall, just like having a house, is essential for growth and development. If you don't have walls to your house, it's not really much of a house, right? Things just kind of leak out, and you really need that around. So a couple components to it include things like peptidoglycan. Again, these are going to be useful for providing things like structural stability. They help with these cross-linking that happens, so you get this nice lattice work type structure to the cell walls. And again, you're going to see that those will differ based on whether you're dealing with a gram-positive or gram-negative bacteria. So it's much thinner you see in a gram-negative bacteria than you would see with something like gram-positive. Again, just a picture kind of showing this. If you notice on the bottom picture here, the lipopolysaccharide outer envelope, you see those a lot in your gram-negative bacteria. Those can be sometimes very difficult to treat bacteria if they have some issues on that lipopolysaccharide coating. It can make it difficult for some drugs to get in, but just to show the difference here between their cell walls. And you can see here in these pictures the cross-linking that's going to be happening here. And you'll see that this is where a lot of different antibiotics are going to be affecting the cell wall by preventing further cross-linking from happening. Is either going to be working against certain proteins, things like your penicillin binding protein. You'll see that that's going to be affected by, as you might imagine, things like penicillin. And then you'll also see things like vancomycin are going to work to prevent these cross-linkings from happening here as well. And so we'll see that when you prevent the cell wall from being repaired or to be propagated, eventually that's going to lead to big holes in the bacteria, and then everything can leak out, and that's going to cause cell death to occur. Right, so that's really important to note with that. Again, looking at your gram stains, again, the gram positives are going to be the ones that are going to be taking up that stain, and that's going to be that cell wall that's really picking up a lot of that. So that's why the dark color versus your gram negatives are going to have that little bit lighter pink color because they have that outer membrane that's not really being doesn't really take up a lot of that the gram stain there. Okay, so don't memorize this here specifically. We'll talk more about these when we get to individual sections. But the thing to note here is just kind of general trends. And so you'll note this, and as you work out in the clinical world, you'll see that, okay, if I'm dealing with a skin and soft tissue infection, there's certain types of bacteria you're going to expect to be causing that infection, right? Just like you would have different ones that are responsible for pulmonary infections, or ones that are responsible for, gynecological infections and things like that. So you kind of get a sense for this over over time, but just to kind of give you guys a brief overture of the common bacteria that are seen in a lot of these different sites, and then you'll see why certain drugs are going to be more effective for those type of infections, because they're just inherently going to be covering those particular bugs, right? So if you look at things like skin and soft tissue infections, what do you see most often? You see a lot of gram-positives. You see things like Staph aureus. You see a lot of things like Staph epidermidis. If you ever have someone who comes in for a spider bite, what is it most often? Probably an abscess, right? It says, we always talk about our MRSA spiders that are biting everybody. They come in with their big abscesses. So again, you'll see that a lot of gram-positives are responsible for these skin and soft tissue infections. You also have some anaerobes too that are potential causative organisms. You'll notice very similar things to bone and joint infections, how again it's going to be a lot of gram-positive causative organisms here, because you imagine the skin, if you had like a puncture wound or something like that, the skin is going to be most likely the source for the bacteria getting in. So you can see that pop up there. Certainly there are exceptions in depending on the type of patient you have, whether or not they have some degree of immunocompromisation and their immune system's not really working that well. They can be more prone to getting kind of atypical bugs that are popping up here, not atypical bacteria, but just things that are not normal for that site. So this is when you see like gram-negative rods showing up for a bone and joint infection. Like if you see that, like it's kind of a bad sign. That's something bad's going on with that patient, right? You also have certain causative organisms that are seen most common, things like meningitis, and these things will change over time as well, especially if you look at things like new vaccinations that come out. So H-flu used to be a much bigger problem, but then when the vaccine came out, everyone was getting vaccinated, you start to see rates of that start to drop. And as such, you may not need to cover for that particular bacteria anymore, and maybe I can use a more focused antibiotic approach that will spare maybe some toxicities and maybe leave out some resistance by being a little bit more narrowly focused and only hitting on the things that are most likely to cause that. And so the best place to really get the most up-to-date information on what the most likely causative organisms are going to be your guidelines, right? So it's going to be things like going to the Infectious Disease Society of America, checking out their website. They have infection-specific guidelines that they have that are really up-to-date and really good. Different things like the American Academy of Pediatrics have certain special ones, and so a lot of that information will eventually get distilled down into the textbooks, but it takes time, right? And infectious disease is constantly evolving, so going to guidelines is really useful to stay up to date on what the most likely organisms are going to be. Looking at the abdomen, we see here a lot of gram-negative bugs, and also we're going to start to see our anaerobes start to pop up, so that's at Bacteroides. You also see a lot of gram-negatives with urinary tract infections as well. Now, there's always going to be some examples where patients will show up with things that are not super common. So if you imagine, the urinary tract should usually be pretty sterile for the most part, right? Right, especially with the natural flushing mechanism of people urinating, like it usually keeps things pretty sterile. Anytime you're entering or you're providing an exogenous foreign body into a site, that's going to be a source for infection, right? So if I put a ET tube down your throat, that's going to be a potential source for introducing new bacteria, right? Because I'm putting something dirty, even though it's sterile, eventually it becomes dirty over time. Just like if I put a urinary catheter in, that's potentially going to be a site for infection. So gram-positives start to pop up. And so if you have patients who have long-term indwelling catheters, they're more likely to get these gram-positive urinary tract infections, which are not really the norm. Normally you would expect to see a lot of gram-negatives. And then for things like oral infections, a lot of anaerobes will be here. So again, certain antibiotics can be better for those type of infections because they'll have anaerobic coverage. When I go over the specific drug classes, we'll see I kind of have like a stoplight mechanism to kind of show you guys just a real brief way to see is this class going to be good for gram-positives, gram-negatives, or anaerobes, and that'll kind of help keep you guys straight. Again, looking at your upper respiratory tract, again, you see a lot of gram-positives, some gram-negatives as well. And the interesting thing here, if you look at your lower respiratory tract infections, I kind of alluded to this, you have these nosocomial infections, and nosocomial means... Yeah, it's like acquired in a healthcare setting, essentially. So, like I always say, hospitals are the worst place to get better, right? Because they're pretty disease laden as it is. And so, if you go work in the ICU and you look at someone who is coming in from the community, say they were otherwise healthy with a pneumonia, their bacteria that they're going to be causing that pneumonia is going to be a lot different than someone who's been there for a month already that has had an ET tube down for a couple weeks. Because of the fact that you're again introducing a new foreign body, you're kind of being surrounded by these other resistant bugs. This is where you see a lot of things like MRSA pneumonia start to pop up here in these nosocomial lower respiratory tract infections. Pseudomonas starts to pop up. A lot of your space bugs will end up showing up here. So these are really much more difficult to treat than you would see with something like a community-based pneumonia. So just a brief overview. You guys remember kind of what's the difference between pharmacokinetics and pharmacodynamics? Anyone know? So if I said that this drug is metabolized by the liver, that would be an example of what? That would be pharmacokinetics, right? Because this is what the body is doing to the drug, right? So if I'm talking about different, absorption, metabolism, distribution, excretion, those are all pharmacokinetic principles. If I'm talking about what the drug is doing to the body, that's going to be considered to be pharmacodynamics, right? Because that's going to be something like, the bacteria is now resistant to this drug. Now I have to use this different drug, or I have to use different dosing of this drug. Those are going to be pharmacodynamic differences, right? So it's important to keep those differences in mind when we talk about, because both are equally important. We'll talk about which one, are going to lead to certain toxicities, or we'll talk about, all kinds of different factors that go into this. So it's important to keep that in mind. Again, absorption obviously is going to be how the drug enters the blood or gets into that central circulation. So it's going to be affected by lots of things. Do you guys cover the term bioavailability? What does that mean?
How much is available after first pass?
Okay, so how much eventually gets absorbed into the body? So if I were to give you a drug via IV push, what would be the bioavailability? 100%, right? So if I were to give it to you orally, it could be anywhere from 0 or it could be 100%, depending on the drug, right? And so you mentioned an important thing called first pass, and what is that? That's that liver tax. As your drug gets absorbed, a certain percentage of it potentially could be metabolized by the liver, and then that whatever gets through is your bioavailability, right? So some drugs are extensively metabolized by the liver, some are not so well absorbed by or metabolized by the liver. So it's going to depend on quite a few factors there. Certainly, different GI factors can affect how well a drug is absorbed. So certainly, things like the acidity of the stomach, whether or not you have other things that are affecting the pH. So if I put in antacids, that would change the pH. It might affect how well a drug gets absorbed. Certainly, if I have something like a high-fat diet, that might affect drug absorption as well. Sometimes it'll increase it, sometimes it'll decrease it. We'll talk about those with drug-specific interactions. And then we have distribution, so that's going to be essentially where the drug ends up within the body. So can anyone kind of define what they think volume of distribution is?
It's the amount of drug distributed into the tissues.
Exactly. So it's going to be basically the extent of how much drug gets distributed out to the tissues versus how much is going to stay within the central circulation. So, and again, when I say central circulation, I mean basically the blood supply, right? It's going to be staying mainly within that area. So something with a high volume of distribution is going to primarily distribute out to where? The tissues or the blood? The tissues, right? It's a high volume distribution. It's going to be dispersing away from the central circulation into the tissues, right? Which could be a good thing, right? Because especially if your infection is there, that might be a really good thing. Something with a low volume distribution is going to tend to stay within that central circulation, right? And that may be better if you have something like, septicemia or bloodstream infection. It might be a better option for them, right? So things to consider. Just as a point of reference, if I ever talk about something having, and every drug has a different volume of distribution. It's normally expressed in terms of liters per kilogram. If I ever talk about something having a high volume of distribution, it's typically going to be over 1 liter per kilogram. Anything with a low volume of distribution will be less than 1 liter per kilogram. That's kind of a good number to keep in mind. It's important for things like will drugs be pulled off by hemodialysis and things like that. We'll also talk about metabolism, how the body is actually changing the drug and how it's getting it prepared for excretion. Because really the whole point of metabolism is to make something in general more polar, to allow it to be excreted through the kidneys, for the most part. Some things will be excreted through the bile, etc. But for the most part, it's getting it ready to go out the kidneys. And so what's kind of the primary, or the first one that jumps to your mind, the biggest kind of hepatic enzyme system that you would think of for metabolizing drugs? Yep, CYP 450, right? Your CYP 450 enzymes are really, really important. What's the most common one you're going to run into? What subset of CYP? It's going to be really good to know because it's going to come up quite a bit. 3A4 is going to be one that's really, really important for that.
I have no idea what you're talking about.
Okay. Absolutely. So thank you for doing that, so I can go ahead and reiterate that. So within the liver, there's lots of different drug metabolizing enzymes, right? So just as a brief overview, there's 2 different phases of interaction or drug metabolism that occurs. There's phase 1 and phase 2 actions, right? Phase 1 metabolism is essentially making the drugs more polar in order to get it ready for either direct excretion to the kidneys or to go through phase 2 metabolism. Phase 2 metabolism itself is going to be basically you're adding on something onto that molecule to make it more polar. So that's where you see things like sulfation, you have glucuronidation, things like that, where you're adding on another molecule to that drug in order for it to be more polar to get excreted through the kidneys, right? So some things can go through phase 1 only, some things will go through phase 1 and then phase 2, some things will only go through phase 2, some will go through none of them at all, right? So it just depends on the drug that you're dealing with. The CYP enzymes are an oxidative class of enzymes that fall into phase 1 metabolism. And so these are the most important enzymes that we'll talk about in regards to drug metabolism, right? Because your CYP450 enzymes are responsible for metabolizing the great majority of drugs that are out there. And most notably, 3A4 is going to be almost responsible for over 50% of the drugs that get metabolized. And so if you were to have something like an enzyme inhibitor, that's going to be a big deal. Alternately, if you have an enzyme inducer, that's going to be a big deal. So say, for instance, I have a drug that is metabolized by CYP3A4, and then now I have a CYP inhibitor come on and inhibit that 3A4 enzyme. What's going to happen to my drug levels for that initial drug? It's going to go up, right? Which may lead to toxicity, could lead to all kinds of problems, right? On the other hand, if I had a CYP3A4 inducer, what should that do to the drug levels? Should go down, right? Because I have more enzymes available to metabolize that drug, okay? So CYP enzymes are going to be super, super important. When they pop up here, especially something being a CYP inhibitor, that's a huge red flag. You should remember that for just for purposes of, your patients are going to have a lot of, an extensive medication list. It's important for you to know those drug interactions, or at least be able to be wise enough to think, okay, I should probably at least look up the interactions and make sure I'm not going to kill my patient, right? So especially, heart medications can be a big one. A lot of hyperlipidemia medications like your statins can be big offenders for interacting with 3A4 inhibitors. It can lead to things like rhabdomyolysis and liver damage, all kinds of bad stuff. So be aware of your CYP enzyme interactions, and when they pop up here, we'll make note of those as they come along. Does that make sense? On the same page? Awesome. Okay, and then we have excretion. So again, a lot of things will either be, mostly it will be excreted through the kidneys. Some things will be, conjugated to bile acids and excreted through the bile tract to eventually go out in the stool. But a lot of things are going to be coming through the urine. And so we'll talk about some drugs that need to be, that have to have their doses adjusted based on the renal clearance. So if a patient has really poor renal function, that needs to be something you need to make note of, because you may need to adjust your drug dose. So you either need to change how often you're giving the drug or how much you're giving of the drug. Because otherwise, what's going to happen? Yeah, you're going to lead the drug levels to rise. You sometimes have kidney issues that pop up. You can have sometimes ear issues that pop up. All kinds of problems that can happen. So in general, make sure you're aware of whether or not a drug needs to be renally adjusted, because that can be a huge, huge source for medical errors as well, right? Especially when you have a patient, and of course I always think in emergency medicine, ICU setting. So think about your 90-year-old grandma who's coming in from the nursing home. You're giving her all kinds of broad spectrum antibiotics. She's septic, starts to get hypotensive. What does that do to her kidney blood flow? It's going to go down, right? So she already has poor renal function because she's 90 years old. She already is getting worse renal function because you are shutting down blood flow to her kidneys. Now all of a sudden, we're adding on these drugs, and if you don't renally adjust those, you can lead to all kinds of problems, right? So it's really, really important to make sure you're looking at the renal dose adjustment that happens here. Okay, so some other things that are specific to infectious disease. We'll talk about the minimal inhibitory concentration, or the minimum inhibitory concentration. So what's this going to be? You guys heard of this before, this term? So this is the level at which the drug must achieve in the blood. And we use, and typically you'll see that when we have therapeutic ranges of drugs, you'll see that we use blood levels of that. And that's a good surrogate for, it doesn't really, we kind of take into account the volume distribution of the drug. So we kind of know, we understand that, based on a blood level of this, we kind of understand what the tissue concentrations are going to be, in general. And we know that this is the minimum concentration we have to achieve within the blood to prevent the bacteria from reproducing. If I drop below the minimum inhibitory concentration, what do the bacteria do? They start to grow, right? If I go above that, what should happen? They don't grow anymore, right? Hopefully it should be dying off, right? It should be allowing my host immune system to come in and kind of knock out the rest of those bacteria. So the minimal inhibitory concentration is really, really important, especially in regards to staying above it. And in general, the drug levels that we're shooting for are going to be 2 to 3 times, sometimes 4 to 5 times above the MIC to make sure we're actually really killing off those bacteria. And of course, you guys ever heard of the term therapeutic index? Mm-hmm. What does that mean?
It's like the minimum dosage for
The range.
without causing harm.
Exactly. So it's kind of a range between the toxic dose 50, the dose that causes toxicity in 50% of the patient, or hopefully not your LD 50. You don't want to be getting even close to that. But you have your toxic dose 50 in comparison to your effective dose 50, right? You want that to be as wide as possible. But you'll see with a lot of these antibiotics, especially some of the ones that are a little bit more difficult to use just based on their toxicities, they generally have a more narrow therapeutic index. And so it's really important that you want to be above that minimum inhibitory concentration to prevent the bacteria from growing, but you also don't want to cross over into that toxic dose level, because otherwise you're going to start to cause toxicity. So this is where therapeutic drug monitoring comes into play really big time for things like aminoglycosides and things like vancomycin. You'll actually have dosing programs where you're measuring blood levels, and you're using that as a surrogate to tell you, okay, well, my blood levels are going to be above where they need to be in order to kill the bacteria, but they're not going to get into the toxic range, right? So MIC is going to be really, really important. We'll talk about that in regards to different ways that the bacteria are going to be killed off by the antibiotics. So then there's two different terms here as well that go along with how the antibiotics are what they're doing to the bacteria. So there's bactericidal and bacteriostatic. And bactericidal means they're going to be killing off the bacteria. That means that you're going to be doing things that are making it so the bacteria itself just dies, right? So imagine if I were to punch a hole directly through the cell membrane. Do you think it's going to kill off the bacteria? Just at least, just having all of its content leaking out everywhere. That should probably kill. If I did that to you, all your guts leaking out, like you'd probably die, right? Same thing happens to bacteria. So if I'm doing something to directly kill off the bacteria, it's called bactericidal. If I'm doing something that just prevents the bacteria from reproducing, that's going to be called bacteriostatic, right? And we'll see that certain drugs fall into the category of being bactericidal. Some of them are going to be bacteriostatic. So bacteriostatic antibiotics are okay. In general, they're generally are good to use because we're not really treating this infection with antibiotic alone. We're also using the host immune system as well, right? We rely upon the patient's immune system to kind of come in and help out the antibiotics in order to take out the infection. So just by inhibiting the growth of the bacteria, that's usually good enough for a lot of the host immune system to come in and knock out the infection. Now, there are cases where this might not be so effective, especially if you have patients who are immunocompromised. So if you have patients who have end-stage cancer, they have something, they have AIDS, anything that is preventing their immune system from really working at top function, it's going to make it more difficult for them to actually take care of the bacterial infection. So in a lot of those cases where you have immunocompromised patients, bactericidal antibiotics are going to be the preferred drugs to go with. Okay, that's a good important point to keep in mind. So again, looking just in broad strokes, things that are going to be affecting cell wall synthesis in general are going to be bactericidal. So this will include things like our penicillins, our cephalosporins, vancomycin. You'll also see things that are affecting DNA directly. Things like fluoroquinolones will also be bactericidal. And then in general, things that are affecting protein synthesis are going to be more on the bacteriostatic side. And so we'll see there's some exceptions here, like the aminoglycosides. They work on protein synthesis, but they're still bactericidal. I don't really have a good reason for that, but that's just how it is. So don't necessarily remember this slide, but just remember as we go moving on and looking at their mechanisms, whether or not you think that's going to be something that's bactericidal versus bacteriostatic.
Are there any cases where they're used in conjunction with each other?
We'd use a bactericidal and a bacteriostatic agent? Absolutely. So there's lots of cases where if you're treating, say, a multi-organism infection, sometimes you will be double covering for a specific infection. That's not a common practice, but you will see it in certain situations where it's warranted, especially when you're talking about things like synergy for certain infections. So sometimes you'll see things like a penicillin being used in conjunction with a different type of antibiotic for synergistic purposes. So certainly you may see that. Yep. Okay, so again, we kind of talked about synergy here. When we're talking about drug levels and we're looking at things like therapeutic drug monitoring, it's important to remember that we're looking at peaks and troughs in general. So peaks is going to be basically the maximum concentration that's achieved after I administer that drug, right? So if I were to give a drug via IV push, when do you think I'd be seeing a peak? Should be like immediately, right? A lot of drugs that you'll see will be infused over 30 minutes, over an hour or so, so it takes more time in order to get to that peak, but it's the highest concentration that you're going to get to. The trough, though, is going to be that minimal concentration that you'll hit before your next dose. So in some cases, you'll be giving a drug one time a day, and your drug levels will drop to 0, and that's your trough, right? So in some other cases, we'll see where it's important that you don't want your drug levels to get that low. We'll talk about why that is in just a minute. And then the other concept is going to be area under the curve, and this is going to be basically the amount of time that the patient is being exposed to a period of drug. And this becomes important when we're talking about whether things are concentration or time-dependent killers. So we'll talk about that I think in the next slide. Okay, here we go. So two different, so we talked about things being bactericidal versus bacteriostatic. Another factor that goes into it that is separate from that concept, so you don't want to get the two mixed up, are the idea of whether or not something is a concentration-dependent or a time-dependent killer. For concentration-dependent killers, the idea is you want to get the drug to a highest level as possible to kill out those bacteria. Okay. even if you drop down below the MIC, these antibiotics are basically so detrimental to the bacteria that they don't really continue to start growing for a period of time. And this is what's called a post-antibiotic effect. So even though I give you a drug, say I give you a big bolus dose via IV push, and I get the drug levels really high, it's going to start to kill off a lot of those bacteria. And then as the levels drop, even though it's below the MIC, the bacteria don't start to reproduce again, right? Because of this post-antibiotic effect. And so that's why you can see some drugs being given, say, 1 time a day, or say twice a day, even though they have a relatively short half-life. You guys know what half-life is? Mm-hmm. What's that? Yeah, time it takes to metabolize half of the amount of drug that's in the body, right? So even though something may have a short half-life, just because you've got that concentration really high, and because of this idea of a post-antibiotic effect, even though your levels drop below the MIC, you're still okay to go, because it's still working in those bacteria. On the other hand, you're going to see that other bacteria or antibiotics are going to be time-dependent killers. And so essentially, these are going to be antibiotics that anytime you drop below the MIC, the bacteria are going to start to regrow again. Right? There's no post-antibiotic effect seen with time-dependent killers. So the longer you can spend above the MIC, the better. So we'll show you some examples of how we can do that. Yes?
So like, it's the only example I can figure out, I can think of. So like, concentration dependent would be like dropping an A-bomb, atomic bomb, and then like, time dependent would be like just shooting bullets until they're all gone.
Yes, if you would like to equate to that, I think that would be, I can see where you're going on that journey.
Okay.
Yes.
It's the only thing I can think of.
Yes, I will show you a picture that will make a little bit more sense of that in a second.
An example of the concentration dependent, would that be like Z-Pack?
Yes, azithromycin would fall into that category.
That's like a short range of time, but then it lasts like...
Yeah, because the drug has a long half-life, so I can give the drug 1 time a day. So usually like a Z-Pack or azithromycin, when you see it dosed, you typically see a big dose up front, usually say 10 mg per kilo, and then on day 1, and then on day 2 through 5, it'll be 5 mg per kilo, right? Just you don't have to remember that number, but that's just how I did peds for a while. I worked at Nomore, so that's what I think. So yeah, so again, and why do I give that bigger dose up front? Why do I start with that big dose as the first dose? Yeah, it's a loading dose. What do loading doses do?
They get your maximum or your concentration high, keep it high, and then you can titrate.
They get us at what state? Steady state, right? Yeah. So instead of giving the drug at lower doses to eventually get up to a steady state, one thing I always kind of harp on is that the time it takes to get to a steady state level is roughly 4 to 5 half-lives. Right, so especially drugs that have really, really long half-lives. Say something like, like an amiodarone, it's an antiarrhythmic that has a half-life of something like 50 and 100 days. That would take forever to get to a steady state. So instead, you use a loading dose to get you up there up front. So with the Z-Packs, you can give a loading dose up front, and because the drug has a very long half-life, I can get away with just doing one time daily dosing, right? So with the time-dependent killers, you want to stay above the MIC as long as possible. So there's a couple ways you could do that. You could say I can give a continuous infusion of a drug. I can give you a drug to infuse for 24 hours a day to achieve my steady state where I want it, above the MIC, and it'll work perfectly, right? But what are some logistical problems with giving us continuous infusion? Resistance. Not resistance. Well, does your patient want to have a continuous infusion? Like, they don't want to have to do that, right? And oral drugs, you can't really do a continuous infusion of oral drugs. That would be kind of a hassle. You'd have to basically either be in the hospital or have some kind of good home health care or something like that. Like, it doesn't really work in a lot of cases. There are some cases where you might use a continuous infusion, but for the most part, you're going to be seeing more intermittent dosing. And so what you'll see, instead of seeing a flat line that's above that MIC, you're going to start to see the vacillation that can occur, right? And so the idea is that you're going to give another dose. As your drug levels start to drop, you give another dose to get you back up to where you want to be, and then it goes down. And so you see this nice normal sine wave that can occur that will keep you above the MIC as long as possible in order to kill off those bacteria, okay? That you could equate it to that, just to keep your levels high, so that way instead of having to deal for breakthrough pain or aches or fever, whatever it happens to be, if you keep it up at a steady level, it'd be kind of similar to that. I'll show you a picture in just a second. So again, looking at the concentration dependent killers, the higher the drug concentration, the greater the killing, and we talked about that post-antibiotic effect. So what's one of the drawbacks if I'm trying to achieve the highest concentration possible? Yeah, you worry about toxicity as well. So that's one of the big things where I can give you a big, huge dose. I can give you enough to kill off all the bacteria, but if I kill off the patient as well, it's not really doing me a whole lot of good, right? So there's got to be a fine balance between how high a concentration I can drive up before you start to see toxicity. And then the time dependent, if you were to look at this picture here, you can kind of see that vacillation that can occur, where if I were to have a missed dose, you would see it drop below the MIC, and then all of a sudden the bacteria start to reproduce, and you run the risk of having therapeutic failures, right? So that's going to be no good. So you keep giving continuous, you give this intermittent dosing on a regular schedule to keep you above that MIC for as long as possible, right? Does that make sense? Everyone's still with me? Every 6 hours, exactly, right? So if you see something that says give it every 24 hours, chances are that's going to be a concentration dependent killer. If I see something that's every 6 hours, it's more likely to be a time-dependent killer, right? And so you'll see where these pop up. So, and the way that they're killing is not inherently related to their mechanism of action. Like when you look at things being either bactericidal or bacteriostatic, in general, you can relate it back to their mechanism. But in this case, when you're looking at concentration versus time-dependent, it doesn't really correlate well. But the better thing to do is just to look at how often it's being dosed, and that's going to give you a good idea of which one it falls into.
Say the post-antibiotic effect was again?
Yep, so post-antibiotic effect. So imagine if this first dose here, you see where it has that missed dose section? You see how the levels drop down below the MIC? If I were to give a concentration-dependent killer, even though the levels are dropping below that MIC, for whatever reason, there's lots of different theories out there, but essentially you don't see the bacteria start to reproduce again for a period of time. So that period of time is called that post-antibiotic effect. And so before the bacteria get to a point where they can start to reproduce again, so just like if you dropped an A-bomb on somewhere, like it's going to take time for people to start repopulating the area, you would, again, give another dose, drop another bomb, and then they're good to go, right? Everyone clear as mud?
You were using another word for the time depending, you said vaccination or something.
Vancomycin.
Is that what you were saying?
Probably.
You were saying something about the graph that it shows something.
Oh, vacillation.
Okay.
Yep. Vacillates. It's my 25-cent word for the day.
Yeah.
Okay, so again, just to give you a good example here, looking at, so this would be an example, if you look at this, that red line, that would be kind of like a concentration-dependent killer, where you give it one big dose, you give that big bolus, you get the level high as you can, and then even though it's dropping down below that MIC, you still have that post-antibiotic effect helping you out. And so in general, again, looking at the way that the drug's being dosed, how often it's being dosed, will give you a good idea of which camp it falls into. Now, there'll be cases where you need to change how often you're giving a drug based on how well the drug's being cleared by the patient. So if you imagine something that I would give every 6 hours, if it's renally cleared and I have a patient with poor renal function, I may need to change how I'm dosing that in order to prevent having drug buildup, right? Because otherwise you're going to see, instead of seeing that nice kind of line where it's very steady, you're going to see it start to climb up and up and up as the patient's renal function decreases. So to prevent that, you would change how often you dose the drug. So you'll see some things, if you look up like a drug reference, you'll see that patient's renal clearance is above 130 mLs per minute, you're dosing every 6 hours. Say it drops below 50, now all of a sudden you're dosing it every 8 hours. And if it drops below 30, it's every 12 hours. So they've done the kinetic studies to know how to prevent that toxicity from building up, or prevent the levels from building up by changing how frequently you give it, right? Okay, so we talked about the post-antibiotic effect. There's lots of different reasons for it. But again, we won't get too much into it. Just know that that's the reason why the concentration-dependent killers are able to be dosed less frequently, and that's why the levels are allowed to be dropped below the MIC, and you don't really see any recurrence of that bacterial growth. Okay. Just continue going through that.
I just want to make sure I heard you right, because you said the reason why, you said the post-antibiotic effect is the reason why concentration-dependent killers are able to be administered less frequently.
Absolutely.
But then they're
Concentration dependent, yeah. Yep.
For the most part, the concentration dependent ones, like the doses that they have made, are they pretty much, have they been tested to make sure that no matter the size of the person, they're not gonna be toxic? Have they been calibrated just in case the person's either too small or too big?
That's a good question. So in general, when you're looking at adult dosing for things, they try to compartmentalize everything into kind of standard dosing, right? So say for instance something like levofloxacin, I'm going to give 750 milligrams say once a day, right? And so that dose is generally going to be a good fit for most of your patients, right? You'll see that in some cases, if you have really large patients, it might not be sufficient for them. If you have really small patients, it might not be good. You know, me coming from the peds world, everything is very weight-based, right? So I'll do everything in milligrams per kilogram dosing because you want to individualize with that patient. Because obviously a 2-year-old patient is going to get a lot different dose than, say, your 16-year-old patient, right? Otherwise, one's going to get weight toxic, one's not going to get enough drug. So in general, you'll see that most of your drugs are being most of them will have kind of standard doses already set up for them, and a lot of the dosage forms already come in that, right? So if you look at something like Zosyn, which is piperacillin and tazobactam, penicillin antibiotic, you'll see that it comes in standard doses where you have the 3.375, you have the 4.5 gram vials that are already set up, and so you know your patient will fall into one of these based on indication or based on their weight, things like that. So they try to kind of set you up for ease of use, but you know depending on your situation, depending on your patient, they may not be useful for them. Okay, so what goes into how I choose the type of drug that I'm going to use? So one, I want to look at the spectrum of activity. So if I have a patient who comes in with a pneumonia, I'm going to treat them with a different bacteria or antibiotic than I would if they came in with a skin and soft tissue infection, right? Because the causative organisms are likely different. So that's going to be affecting what drug I'm going to use. You want to look at the kinetics of it. So will the patient be able to absorb this medication? Is the patient going to be distributing it normally, right? What are some situations where distribution might change? Hmm? Okay, so certainly that would be one factor, whether or not you take oral. But what would be something that could affect distribution of the drug in the body? Or something like disease? Yeah, heart failure is a big one. So anything you have like fluid buildup, that's going to affect hydrophilic medications, and so that's going to be affecting how far distributed they get for sure. So certainly look at factors of distribution. Also look at eliminations. That's where, you know, again, do they have really significant hepatic impairment? Do they have really significant renal impairment? That can be a big thing as well. Kind of what you're talking about kind of goes back to things like dosage forms. You know, is a tablet going to be useful for my patient if they can't swallow tablets? You know, it's funny, like when you're in the hospital and you're, you know, something I see with teenagers a lot, you know, the doc will put in the order and it'll be dosed at 8 and 8. Well, a lot of kids don't get up until like 10 or 11 o'clock, so the nurse is like, you can just retime this, I can give it 11 and 11. So, okay, that makes sense, you know. So you have to look at things like dosage forms and the dosage regimens you might try based on patient specifics. That's a very good point. Again, look at whether or not things are going to be bactericidal versus static, which is important if your patient's immunocompromised. We look at things like time-dependent versus concentration-dependent killing. Again, a lot of those things are already kind of figured out for you when you go to your reference and it says dose, you know, 600 milligrams every 6 hours. Like a lot of those things have already been kind of figured out for the most part. But it's good to have an underlying knowledge of why those things are the way they are. And then you want to look at toxicities as well. So looking at things like GI toxicities, anything hematologic, CNS, stuff that will pop up. And we'll talk about specific adverse effects that can pop up with certain drugs. Again, a lot of times you're going to be giving antibiotics to patients without necessarily knowing what the causative organism is. And so when you are giving a drug, especially one that is considered to be a broad spectrum antibiotic, that you are hoping to cover whatever you think the patient has, that's called empiric therapy, right? So if I know a patient is going to be coming in with a skin, soft, and tissue infection, I think it's cellulitis, I'm going to be thinking, you know, staph. I'm thinking staph epidermidis, MRSA, or you know, MSSA. Those are things I'm going to be thinking about. I'm going to say, well, clindamycin is probably going to be good for that. And so you go ahead and give that. I have no idea if that patient actually has that bacteria or not, but I'm guessing it's probably going to be working for that, right? So that's called an empiric therapy. When you do cultures, though, that's when you can have your identities come back and you can figure out what the actual resistance is for the drugs, and you can tailor a very specific drug, a more narrow spectrum drug for that specific bacteria, right? So broad spectrum is going to be something that covers a lot of different bacteria. I want to use narrow spectrum whenever I can. We'll talk about resistance in a second, in order to treat as few bacteria as possible to try to pinpoint it and just use it against that one type of bacteria. That makes sense? So always try to streamline therapy whenever you can based on the identity that pops up. Certainly resistance is going to be a big issue. Oh, go ahead.
What do you call it? Broad spectrum treatment?
Empiric therapy.
Spell that?
EMPIRIC. Yeah, so just like you would have, you know, empiric therapy for, you know, your first line, second line drugs for hypertension, you would have similar first-line, second-line drugs for, say, otitis media, right? And so that's empiric therapy. You don't know specifically what the organism is, but you have a good idea that what your drugs are probably going to cover it, right? Certainly resistance is going to be a big issue. Obviously, anyone that comes in with a cold, you don't want to prescribe antibiotics because it's most likely a virus. You don't want to do that, right? That gives EPAX to everyone. I always hate that. And certainly environmental exposures can be a big source for resistant bacteria. A lot of antibiotics get given to animals in order to keep them healthy, and we get kind of exposed to a lot of those bacteria that are resistant as well, so that can be a big source. And then, you can definitely have strains of different bacteria that are resistant to almost all known drugs. And those are kind of these super bugs we'll talk about. A lot of them end up being those space bugs. Certainly Klebsiella kind of falls in that category as well. That's why they have the ESCAPE acronym. And so those can be really, really difficult to treat. Okay, kind of mentioned a lot of these. So again, bactericidal is going to be something that kills the bacteria. Bacteriostatic just inhibits growth. And then again, we talked a little bit about patient-specific factors as well. So you'll see that depending on where you think the infection is, certain bacteria or certain antibiotics may not be able to get to sufficient concentrations to treat that infection. So if you think about something like meningitis, right, that's an infection in the CNS. In general, your blood-brain barrier is trying to keep out all drugs and toxins away from the brain as much as possible. So you want antibiotics that are tailor-made to actually go into the CNS. And so you'll see that some will be able to cross very well, some won't be able to cross very well at all. And so that can be important. So if your drug can't get to the site of infection, it's not going to be effective. We talked about the immune system issues, and then also age can be important as well. So certainly looking at things like there's drug-specific cases where you don't want to give tetracyclines to kids who are less than 8 because it can actually stain their teeth, right? Chloramphenicol shouldn't be given to very young children, especially neonates, because it can cause this issue called gray baby syndrome, since they can't actually metabolize it themselves due to the kind of immature hepatic enzymes. So that can really be an important factor there. Okay, so again, looking at other physiologic status, so again, looking at renal function. So again, renal function being altered could change what factor of pharmacokinetics? It could affect distribution if you have fluid buildup, absolutely, but more importantly, it affects excretion, right? Because the kidneys are mainly going to be excreting the drug. With the hepatic function being altered, that can affect what? Usually metabolism, right? There are some cases where it can affect distribution as well. So if you think about like your ascites patient who has really bad hepatitis and have a huge ascites, huge belly, that could be a big reservoir for a lot of drugs to go to, so that can affect distribution. Diabetes can sometimes affect things like, certain patients might be more predisposed to different types of infections based on their disease state. So especially diabetic patients, you might think like diabetic foot because they have, that neuropathy that occurs and they don't even know they have an infection down there. They can't feel it. And then certainly you worry about things like pregnancy status. So whether or not the drugs that you're giving are going to be affecting the baby at all. Certainly look at allergies are going to be important as well. And what's, whenever someone says I have an allergy to, say, penicillin, what's the next question you should ask? Yeah, what happened, right? What kind of allergy did you have? Because if they say diarrhea, probably not an allergy, right? It's a side effect. So it's really, really important because in a lot of cases you can have patients who are essentially cutting off a huge swath of antibiotics from being used if they say they're allergic to it, right? And so some people are very skittish and they don't want to test it. They're saying, I don't want to do it. So I'm just not going to give it to them, and I'll do something else that's like totally not preferred. Some people are a little more cavalier about trying it, but it's important to get a good history to find out exactly what happened. And so penicillin allergies is one of the things we'll talk about in specific regards to this. Certainly look at prior adverse drug reactions. If you know a patient had Stevens-Johnson syndrome after receiving Bactrim, don't use Bactrim again, right? So it's important to get a good history of what they've received before, and then look at other contraindications as well. Okay. I'll give you guys a break in just a minute. Let me finish this little section here. So the use of combination therapy. In general, do not use combination therapy for a single infection, right? What are some problems if I use combo drugs when it's not really warranted? Resistance, right? Because anytime I'm applying the selective pressure to the bacteria, you run the risk of having more resistant strains pop up, right? It's just kind of evolution to some degree. You're just going to have those resistant bugs start to develop. Some cases where it might be useful to use multi-drug regimens is going to be if you don't know what the causative organism is, especially if you're worried about really severe infections. So think about like your 90-year-old grandma coming from a nursing home for sepsis, right? That's a patient who could have really nasty gram-positives, could have gram-negatives. I'm not really sure. I'm going to use a multi-drug regimen in order to make sure I cover all of that until cultures come back and I figure out what it is, right? So that would be one case. So certainly you'll see things like surviving sepsis campaigns and things like that where the early application of those antibiotics has led to better mortality rates. And so something's really important there. Sometimes you'll see infections that are due to multiple organisms at the same time. So if you're worried about polymicrobial infections, especially in the abdominal cavity, if you have a ruptured appendicitis or something like that, you can see combinations of gram-negative bugs, you can see anaerobic bugs. Sometimes just one drug by itself isn't going to be enough to cover that whole spectrum. You have to add on another one in order to help get a little bit broader spectrum and cover all those bacteria. So that might be a case where you need to do that. Some cases where you'll see synergy being used, you'll see penicillins plus an aminoglycoside in some cases being used for things like Pseudomonas infections, sometimes for endocarditis treatment, things like that. In some cases, you might be able to get away with lower doses of antimicrobial agents, but that's kind of more the rare exception than the rule. So again, in general, one drug, whenever possible, is going to be better for your patient. So if there are some cases where you want to use prophylactic antibiotics, and what would prophylactic mean in this case? Yeah, so you're going to give it, and they're at risk for developing an infection, so I'm going to give it beforehand to prevent them from getting an infection. So certainly if you have patients who have like heart valve replacements, or in a lot of surgical cases, you want to prevent the infection from happening, so you'll give prophylactic antibiotics. Again, if you use this inappropriately, then you run the risk of having the resistance pop up. Same thing like giving a Z-Pack to a patient who may as well have a viral infection, right? Resistance can be an issue there. Also, looking at other issues of misuse with antibiotics, if you're using improper dosage, especially based on the indication. Sometimes you can use way too low of a dose, and the drug levels are not getting high enough at the site of infection. Can be a problem. Things like surgical drainage can be really important. So, non-pharmacologic therapy for some of these infections can be super important, because again, if you have a big giant abscess and you keep giving antibiotics, sometimes you're not going to be able to get to the core of that abscess, right? Sometimes you need that drainage in order to get rid of all the nasty gunk, and then you can treat the kind of residual around it, right? So drainage can be really important in those kind of cases. You really want to make sure you have good, adequate bacteriological information, so it's getting your cultures and being able to make informed decisions on that. So say I have a patient who's coming in who is septic. Do I want to give the antibiotics first, or do I want to get my cultures first? Why do you want to get cultures first? Yeah, so basically, if I give the antibiotics first, that has the potential to affect how my culture results come back. So if I start to kill off some of the bacteria, the thing that's actually the causative organism might not show up, right? So I may get misinformation about what the actual causative organism is. So always get your cultures first whenever possible. Now, if I was at a case where it's like, well, our machine's down, it's going to take us 3 hours to be able to get the cultures, draw the blood, but if there's anything delaying you, if it's meningitis, get the antibiotics on board, it could lead to pretty negative patient outcomes. But in general, get your cultures first. Okay, so how do we test for bacterial resistance? So have you guys seen these type of tests done before? So what's this left slide here, or this left picture? Okay. It's a Petri dish, yes, absolutely. So this is a disc diffusion test. Okay, so what are the different little discs in there? Right, so different types of antibiotics, and so the bigger the circle, the better, right? Because that's a bigger zone of inhibition. Because obviously the concentration is highest at the disc, and as you get farther and farther away, the concentration just by basic diffusion gets lower and lower, and so that kind of tells you how low the concentration get before the bacteria start to reproduce, right? Kind of gives you an idea what that minimum inhibitory concentration should be. So that's one good way to do it. A little bit easier way to get an idea of the concentration you should be shooting for would be one of these E-tests, where basically you have these strips that are impregnated with different concentrations of the drug, and you can see here, like on the top strip, obviously the right side has the biggest concentration because that's what's having the biggest zone of inhibition, and then as you get the concentrations lower and lower, you start to see where the bacteria become more intermediate and more resistant. And so most often when you see resistance reports come back or cultural results come back, you'll see it's either susceptible, intermediate, or resistant. And in general, you only want to go for things that are susceptible. Intermediate is really not going to be no good because your chances for failure are going to be too high in those cases. So has anyone heard of a hospital antibiogram? I know what this is. Okay, so this is something you're going to see every hospital have basically, and so these are really, really handy things. So like we said with empiric therapy, right? It's going to be treatment regimens that are designed to get the most likely organisms, right? So I'm thinking it's a skin and soft tissue infection. I think it's probably going to be this. I'm going to use this bacteria or this antibiotic because I'm pretty sure it's going to cover it, right? And so antibiograms are really nice because it actually takes isolates from your location in order to determine what the resistance rates are actually going to be. So even though I'm pretty sure clindamycin is going to be good for treating methicillin-sensitive Staph aureus, you might be in a place where you're working where it's absolutely resistant, right? So what this basically is doing is it gives you the antibiotics here on the x-axis, and then they have the bacterias on the y-axis here. And those numbers, the first one's going to be the number of isolates they had, the number of basically the tests that they've done, and then that number with all the antibiotics is going to be the resistance, or I guess the susceptibility rate. So if you look at something like Acinetobacter and the amikacins, that first drug on there, so the very top left box, is 95% susceptible. That's pretty good, right? You wouldn't want to use something that's like 60% susceptible, because then you run a chance of, there's a 40% chance that your antibiotic's going to fail. You don't want to do that, right? You want to get these infections treated the first time. So these are super useful, because you'll see that, even going from somewhere like in Jacksonville, you'll have a different looking antibiogram than you would see in, say, Orlando. Or say, for instance, if you were working out in the country versus working in the inner city, you're going to be seeing different rates of different resistance patterns there, right? So it's really important to have an idea of what you're working with. So a really good example of this is that, obviously you need isolates in order to run these tests. You have to have an adequate number to actually show that this is good data, usually around 30 or so in order for it to really be valid. When we first opened up Nemours in 2012, well, we didn't have any isolates, right? So we can't really have a good antibiogram, but we knew that we're in Orlando. Okay, there's other children's hospitals. They probably got the same kids coming to us as going to them, most likely. So we were actually able to, kind of steal their antibiograms and at least have an idea of what the common resistance rates were, right? So this is really handy for the emergency department, where people are just coming in off the street. You want to be able to make sure you're getting the right antibiotics the first time. That was really handy there. And then eventually, after we were open for a couple of years, we had enough strains isolated out. We could then make our own antibiogram. And that's an ongoing process. It's something that should be updated every single year. So if you go to work in a hospital, it's a good idea to take a look at their antibiogram to make sure you're prescribing the right things. Okay, so how can we control the emergence of resistance is really going to be important, because you guys are going to be prescribers, so you want to make sure you're doing the right thing. Don't do this. You just throw something at the wall and hope it sticks. No, that's the old way to do it. We're not going to do that anymore. So really the big concern is that we have these super bugs that are starting to pop up. So we have things like MRSA that are coming up in higher rates. That's that methicillin-resistant Staph aureus. You have things like VRE, which is vancomycin-resistant Enterococcus. That can be really, really nasty. VRSA. So usually when you have MRSA, you can't use it to treat with anything. You go with vancomycin. That's usually your good go-to. You have vancomycin-resistant Staph aureus. Okay, well, I'm out of vancomycin. Now what do I do, right? There's a limited number of antibiotics you can jump to. So that's kind of the problem on the gram-positive side. And then it's even worse on the gram-negative side. So you have things like bacteria that can produce these substances. And so we'll talk about beta-lactamases, but that ESBL stands for extended spectrum beta-lactamase. So usually if I have a bacteria that's producing beta-lactamase, I can use a beta-lactamase inhibitor. Makes sense? But sometimes they're so potent, beta-lactamases, that they kind of kill everything, right, antibiotic-wise. So those can be really nasty. You also have Klebsiella producing carbapenemases. And don't get too hung up on it. Just know that that's something that can be produced. They'll end up rendering a lot of your really big gun antibiotics inert. So that's not really going to be. You have to use unpreferred antibiotics in a lot of cases. Things that sometimes have a lot of toxicity associated with them. And so you see a lot of these multi-drug resistant infections. Like 70% of them are going to be stuff that comes from the ESCAPE acronyms, like Klebsiella, E. coli, Pseudomonas, and Acinetobacter. So those are really some of your big ones you want to focus on. So obviously indiscriminate antimicrobial use can be a big thing that leads to resistance. We talked about a lot of these. So again, not following your guidelines. So if resistances have changed and you're not really using the appropriate antibiotics based on the updated guidelines, that can be a problem. If you're double covering when it's not really warranted, that can lead to resistance. Not de-escalating therapy. So if I were to get my culture results back, say I'm treating one type of bacteria with 2 different antibiotics as empiric therapy, and I get my culture results back, I should really just streamline and downgrade just to 1 antibiotic, right? So if I don't do that, then you're applying that selective pressure and you're going to get resistant bugs. And then treating for too long. So again, looking at the preferred number of days treatment. So again, if I treat for something for 21 days, that's just going to lead to more resistance and not necessarily a better cure. Obviously, people who are in the hospital for longer stays are going to get more likely to get these multi-drug resistant bacteria. And then also looking at prior antibiotic use. So patients who have repeated courses of broad spectrum antibiotics or have repeated courses of prophylactic antibiotics are more likely to get one of these resistant bacteria strains, right? Like we talked about the meat production, getting a lot of antibiotics put into your animals leads to a lot of resistance as well. How does the resistance develop? I'm sure you guys have covered some of this in microbiology, so you guys know that plasmids exchange is a really big one. Bacteria are able to share some of their resistance patterns. some of the things that they can do to do this is, one, they can change the site of where the antibiotic is going to work, right? So say, for instance, your penicillins work against penicillin binding protein. If I change that penicillin binding protein to where the receptor site is completely different, that penicillin can't really bind to it anymore. That's one method. You could have certain bacteria that produce efflux pumps that would actually pump the antibiotic out of the bacteria to prevent it from having its mechanism of action. You can see things like accessory pathways being used. So, if I'm preventing DNA synthesis by blocking this one pathway, the bacteria can kind of circumvent that, and it might be able to do that to get around the antibiotics. So there's lots of different methods. But again, the big thing is to, again, use your guidelines, de-escalate therapy when it's appropriate, and hopefully you won't run into a lot of these issues. Again, unless you're working in like the medical ICU, and you're going to see a lot of this stuff pop up. So there's lots of different methods to help control this. So if you guys work in a hospital, you probably have an antimicrobial stewardship committee that are really responsible for doing a lot of these things here. So doing things like restricting certain antibiotics on the formulary. So like at Nemours, there are certain broad spectrum antibiotics we would not let prescribers use unless they had an ID consult and the infectious disease doc called up and said, hey, it's okay to use, right? Because you don't want to use this drug inappropriately. Certainly looking at things like pharmacokinetic dosing programs are really important. De-escalation of therapy, treatment guidelines, all these things can help to prevent that emergence of resistance. The other thing you can do as well is also cycling certain antibiotics. So say, for instance, you have your aminoglycosides. It's made up of 3 main drug components. You might go through, say, a period of a year or 2 where you use gentamicin, and then once you start to see resistance patterns pop up to that, you switch over to use tobramycin instead, and then you use amikacin, right? So by cycling that, you prevent the resistance from getting too overwhelming for that whole class of antibiotics.
And you mean for like, as a population, like not just for one patient, you mean for like if you're seeing...
Exactly, yeah, so this would be like within like a hospital itself, you would switch over time from one to the other. Yep. Okay, so we are eventually going to get into the different antimicrobial classifications. We'll see that the main categories are going to be those that are going to be affecting the cell wall synthesis. Some can affect the cell membrane itself. You'll see a lot of them are going to work in protein synthesis. You'll see some are going through certain metabolism pathways and will inhibit that, and then we'll see some that are working on the DNA level. So those are going to be your main categories, and we'll get into those in the next unit. Here's a good picture that just kind of shows you where the different classes are going to fall into. So I won't kind of belabor this point because we're going to get into it in the next unit in just a second here. Okay, so any questions on this first section? Okay.